Welcome back, ladies and gentlemen. We are going to be looking at Chapter 2, Key Issue 3 and 4 today. And the big questions are, why does health vary by region? And why might population change in the future? So we start off by looking at health and how that can vary from region to region. We usually look at medical facilities, and so the doctors or nurses or hospital beds per capita of the whatever region we happen to be looking at. We also look at regional government expenditures can vary from developed areas to developing regions around the world. Most developed countries pay for most of the health care that people receive, so about 70%. Your big exception here is actually us. It's the United States. We see that the government pays for roughly 55% of the cost, and that's not on par with other more developed countries around the world. In fact, you can see annual per capita expenditures are 10 times greater in developing countries compared to developed. There's a little typo there. It should be developed countries around the world. All right, and so big questions that we see on the horizon and even currently out in the media are, should the United States adopt universal health care? And what would universal health care look like in the United States? Again, there's a lot of countries around the world that use it, but we don't know exactly what it would look like here in the United States. And that's a hot button issue that you'll hear on the campaign trail. You'll hear it after the campaign. You hear it quite a bit involving government. We look at hospitals per 10,000 people, and you can see that hospital beds here, that the United States is not on par with some of those more developed regions around the world. Right? You look at Europe, they are in the 50 and above region. Even Australia, you can see they're in the 30 to 49, but the United States is in that kind of purple region there, the 10 to 29, which means we're not quite on par when we look at hospital beds per 10,000 people as we are with the other MDCs. Here's physicians per 10,000 people. Same thing. You can see, again, quite a bit in Europe. Most of those same countries we just saw highlighted with the darkest color, we still see in the darkest color here as well, right? Hospital beds and physicians tend to apply to each other. And then finally, we look at healthcare expenditures. And the United States is at the top category here. So you can see that healthcare expenditures per capita are about $1,000 and above. And so the United States, Canada, Western Europe all fall into there. You can see Japan in there and Australia. So most of the more developed regions are on par with the costs. The exception is that our government isn't picking up the cost of most of that, right? The people are a lot of times. So we look at how healthcare and gender can intersect with each other. And when we look at the healthcare and gender, we talk about the maternal mortality rate, the MMR. And this is the annual number of female deaths per 100,000 people related to pregnancy. And so basically women die. This is a pretty common occurrence around the world, especially in developing nations. Women die in childbirth fairly regularly. And so in developed countries, we have facilities to catch any issues that might arise during births before they become deadly, so that we can help save the mother, save the child. But that's not always the case in other parts of the world. Again, the United States is a bit of an exception here. We do have we see a lot of our lower income areas and non-insured areas, and we see kind of a higher rate of MMR versus other more developed countries around the world. Okay. Here's again the maternal mortality rate. You can see what it looks like. And again, most of them coming in sub-Saharan Africa. We've talked a little bit about sub-Saharan Africa and the idea that we're going to see a higher total fertility rate there. And that's because a lot of those children are going to die. Well, mothers tend to die in childbirth there too, because they don't have the services they need to be safe in those delivery situations. Here's the United States, MMR, and you can see kind of the regions where maternal mortality rate is an issue, right? Definitely in the South. We can see there's a couple other spots too that pop up, but we definitely can see those regions there, and we'll talk a little bit more about some of the spatial analysis later on. We also can look at sex structure and why sex structure is important. We talk about the idea of sex ratio, and this is the number of males per 100 females. And when we look at it in Europe, it's 93 males to 100 females. In Africa, it's about 103 males to 100 females. And so we look at this, and this is an important idea when we talk about sex structure, and that's because of the number of females you need for your society to continue to be on the 2.1 population, all right, that replacement rate that we talk about. And so if you look at what accounts for some of these differences, well, if Africa has more males than females, one of the reasons for that, if we look back at the last couple maps, spatial analysis idea here is, well, if more women are dying in childbirth, that would be why there are more men than there are women. All right, and so that's a big part of that there. So how are baby girls at risk in the world? When we talk about baby girls, there's some countries where we see some missing aspects here. So baby girls in India and China, and we look at them as missing and not necessarily culturally preferred a lot of times. And there's some reasons behind that. Women in China are not necessarily as important to the culture because they are a very patrilineal culture. They rely on their son after they are old to take care of the parents. And so if they don't have a son, then they have no one to take care of them as they age. And so that's a big aspect of that culture. We also look at the sex ratios here of China and India, and you can see it's about 114 males to 100 females. In China, 112 to 100 females in India. So definitely the sex ratio and sex structure is skewed towards males in both of those cultures. We also look at the idea of sex selection based on gender and inequality and the cultural bias towards having sons over daughters. Again, it is an economic aspect where the men or the sons will take care of the family after the family gets old, the parents get old. Okay. So when we look at some of the demographic issues that may happen in India and China, it comes down to gender equality and gender inequality. Right, and the idea that if you have more males than you have females, well, now you're going to have a harder time continuing your reproductive rates. And so that 2.1 replacement rate becomes more difficult. How do the elderly affect population? We talk about life expectancy, the average number of years that a person can expect to live given current social, economic, and medical conditions. And so we look at it in more developed countries and regions. We look at it like in Europe at about 81 years old. That's the highest of those. We look at it in sub-Saharan Africa at about only 60 years old. All right, so we see the more developed versus the less developed here. And obviously the higher life expectancy means that you're going to have a more elderly population. And that can become an issue when we talk about the idea of potential support ratio. If you look at the elderly support ratio down here, it's the number of working age people between the age 15 and 64 divided by the number of people that are 65 plus. We usually look at 65 at being the age when most people retire. And they can draw on like Social Security benefits at 65. And so those are people that are no longer in the workforce. And so they are no longer helping to pay their own Social Security rates. They're not helping to pay for anyone else who's retired at that point. And so they become part of the dependency ratio here, or in this case, the elderly potential support ratio. So currently at 9 working people per elderly person, but we will see a shift by the year 2050 to about 4 working people for every elderly person. And so that becomes a much larger burden as the age starts to creep up on our life expectancy, even in the US. And so if we go back and look at some of the policies, China had the one child policy in effect for a long time. And what caused that, or I should say what was the issue that came about with that, was that they were having less babies, less children, and then they were having more elderly people as people lived to older ages. And so now their population pyramid, which we'll get to in a little bit, is kind of flipped. They have a very elderly society. They got very old very quickly, and now they don't have the number of people that they need to support those elderly people in the working force. So we look at life expectancy at birth around the world. Again, you can see most of the MDCs are right around 75 to 80 and above. So we go back real quick. We look at sub-Saharan Africa, obviously, as below 70. We see that across India, Pakistan, Iran as well. Life expectancy by race and ethnicity, you can kind of see where we're at here, the U.S. overall, and then we kind of break it down between male and female. And I mean, this is kind of the big idea: is guys do stupid things, and so guys tend not to live as long as women do, and we can see that pretty much in all of our data. Women tend to live longer lives than men do, and again, guys, I'm sorry, it's just because we tend to do some stupid stuff. Here's your potential workers to elderly. We look at 1950 in the blue, And then we look at 2015 in the red, and now we're looking at the number of workers versus the elderly here in 2050, or the projected 2050. And you can see that everything is lower. Nigeria is still pretty high, but theirs is lower than it has been too. So the number of workers, working age people 15 to 64 that it takes to support someone who's 65 plus. And so then we get into population pyramids, which I just mentioned a minute ago, talking about population having two major factors that kind of influence it in the structure of this pyramid here. The first is our age structure, and the second is our sex structure. So you can see that this pyramid is divided by blue and red. Your blue side is male, your red side is female, and then on the far right side you can see the different ages. And so the very first row at the very bottom down there is 0 to 4. So those are the number of people in that society in the United States that are between the ages of 0 and 4. And we can kind of work our way up. And you can see if we go all the way up to the top, you can see the people who are 100 or older at the very top. And obviously, that's a very small bar. But you can see that the bars on the female side, as we get older, are longer because there are more women, and women tend to have a longer lifespan than men do. But both statistics are represented in this population pyramid here. And the shape of the pyramid then is tied to the demographic transition stages that we talked about the other day. And so you do need to know what each shape looks like of the pyramid in each stage of the demographic transition. And so here's our first one. This is the Gambia, and this is stage 2. And you can see it basically looks like a pyramid, right? You've got a larger base, meaning there's a lot younger population. And as you get older, people don't live as old to be as old. Life expectancy rates are lower. And so we have this kind of traditional pyramid-looking shape in stage 2. In stage 3, we can see we kind of have this bubble in the middle there where things are starting to, we still have that original pyramid as you go up to, say, the age of like 30 or 25 even. You still have that kind of pyramid shape at the top. And then from there, you can see it kind of kind of gets a little bit more slender, or kind of works its way straight down from there. And that is where we start to see the death rates and the birth rates starting to change more with stage 3 in our demographic transition model. And then finally, we look at Denmark here as our stage 4 example. And you can see that everything's still present up at the top around 65. You still have the pyramid up there. Then you've got kind of the Coke bottle shape at the top up there as stage 3 starts to take over. And you can see things are starting to narrow out now at the bottom down here, starting around the age of 15 to 19 and lower. That we see that things are starting to decrease. So we have a smaller birth rates in stage 4. And so when we look at why is age structure important when we talk about this, all right, this idea is, we just talked about the number of working class people it takes to also satisfy the number of retirees or whatever. When we look at dependency ratio here, that's a big aspect of this. And so the dependency ratio takes into account the retired people, but also the people who are between the ages of 0 and 14. And this is the percentage of dependent and productive members of the population. So the productive members are people who are age 15 to 64. Those are your workers. Those are your laborers who are continuing to make money. And they are the ones that then are supplying the money and the aid to the people who are either 0 to 14 or 65 plus. And so if you look at it, it's not good to have too many young people or too many old people in a society. You need to have that fine line between the 15 to 64-year-old workers and the other two aspects here too, because that gives you enough money and it gives you enough population to support the people that are dependent on that working group, that 15 to 64 group. Now we're going to take a little look at the epidemiological transition. And so this goes right along with the demographic transition model and the stages here, and it identifies the distinctive causes of death in each of those stages. And so when we look at stage 1, we tend to see pestilence and famine. So if we want to look at an example of this, we would think of like the Black Plague or the Black Death in the 1300s in Europe and Asia as being kind of this idea of pestilence and famine at that point. Okay, if we were to look at stage 2, we have what we call receding pandemics. And one of the best examples of this would be cholera of the 1800s. And then we get to stage 3 and stage 4, and we have what we call delayed degenerative diseases. And so that's things like heart disease and cancer, longer life issues where you might have some kind of degenerative disease as you get older. All right, and so we look at longer life expectancies, and that causes the cancers, the heart diseases, and the degenerative aspects of the diseases. Okay. And also look at lifestyle choices. A lot of times in those stages 3 and 4, we start to see good lifestyle choices versus bad lifestyle choices as being some of the issues here. Something that's not in your book, but we should all know a little bit about is this idea of what we call an endemic, an epidemic, and a pandemic. All right, so an endemic is a disease that is contained to a small area. An epidemic is a disease that is spread over a region. And a pandemic, we all should know a little bit about, is a disease that has some kind of global scope to it. All right, and I think we all know about pandemics after the last year, or should I say 2020 anyway. So here's when we look at cancer, which is a degenerative disease, and opioid deaths. So you can see here some of these other aspects of the stage 3 and stage 4 here. All those more developed countries tend to see higher purple colors there when we look at the cancer rates. Same thing when we look at some of the opioid deaths as well. A lot of the MDCs, not all of them, a lot of the MDCs tend to have higher opioid deaths here too. All right, looking at the drug issues with degenerative problems, right? Painkillers. When we talk about obesity rates, again, this is that kind of good lifestyle versus bad lifestyle choices. You can see the United States almost always number one when we talk about obesity rates. Not quite the same in the other parts of the world. But yes, we do fall into that poor lifestyle choices. So lifestyle diseases like diabetes and other aspects, which come on later in life if you aren't taking care of yourself. We see the United States as being one of those countries. Finally, something you guys haven't talked about yet is the one of the other stages of the demographic transition model, and this is a stage that sort of exists. We have evidence that it exists, but we haven't gone to the point of saying yes, this is it. We talk about stage 5 of the demographic transition model, which would be a negative growth stage. And so some demographers are arguing that this 5th stage is starting to emerge worldwide, where the crude death rate now exceeds the crude birth rate. And we see this in 2 main areas. We see it in Japan for sure. We also see it in Eastern European countries. And when we talk about Eastern European countries, there is a reason for that. When we talk about poverty and some of the other aspects of that society, we look at governmental issues that they had in the 80s and 90s. That have maybe caused this negative growth. People didn't want to bring babies into a world where their government couldn't be trusted or the economy wasn't stable. And so we see this negative growth rate where more people are dying than are being born in some of those countries. All right. And so when we look at in which stage do you think a country has the highest population, right? As we go through, we'll talk more about that, but we talk about like stage 4, we still see pretty high populations, right? Even though that we're seeing birth rates decline, we are still seeing high populations in general. So we take a look at the fertility assumption here as you look into it, and you can see that we have the different levels here, the low, medium, and high. And you can see that we're kind of extrapolating out from the year 2020 and beyond. And so anything really from beyond 2020 we look at as extra projection here. But you can see that high fertility assumption. So plus 0.5 children is the highest level there. And so we're looking at the prediction interval at about 95%. So that's our world population as we continue to grow. So somewhere between, in this kind of pinkish area, somewhere between the median and the prediction levels there. So our population being around 11.2 billion by the year 2100. That's a lot of people, all right, a lot more than we have right now. Here's our possible stage 5, and you can see what happens in stage 5 where we have that decline. Your natural increase rate starts to decline in stage 4, and it goes through and actually eventually when we get to stage 5 ends up negative, and your death rate has perked up and it now is above the birth rate, and your birth rate is below the death rate. And that's where we see, again, Eastern European countries and Japan as the places where we are seeing that currently happening. So there's Japan's predicted population pyramid. From 1950, you can see they're pretty much stage 2 country at that point. versus in 2050, what their projected population pyramid will look like. And you can see, yes, there's obviously a lot of decrease. It's essentially an upside down pyramid where you've got more elderly people than you have younger people. And so we talk about all the problems that could go along with that, right? Dependency ratio and the idea of some of the other cultural issues that have occurred here. But again, it does look like they are in some sort of stage 5 of the development. So what can they do to kind of help those things? We look at some of these things that have affected population like this. And so one of those is anti-natalist population policies. And so these are policies that the government has put in place to help reduce the crude birth rate. So some kind of restrictive policy. And the most famous of those is China's one-child policy. It was in effect all the way till 2016, and it has definitely affected their policy, their country's population. We see that parents have essentially had just one child. It wasn't that they couldn't have another; they would have had to pay taxes on it, or at least identify that they had another one to pay extra taxes for that child. And so it could be done, but it was very rare. And in that child's with that child policy, it was very rare, even still today, even though the policy is over, for families to have more than one child. It's just become kind of part of their culture. When in India, this one is really an interesting one. They basically took people and they offered a sterilization program in the 1970s. And the idea was that if someone's had one or two children, then they should go into this sterilization program, and men were sterilized so that they wouldn't have any more kids. That is actually not the way it ended up working, though. It ended up working that most people who have already had 4 or 5 kids went in to get the sterilization done, and so it wasn't really accomplishing their goal. There was also the controversial aspect of people who were criminals were sterilized as their penalty for their crimes, which is extremely controversial, obviously. That's something that's really not medically done, obviously. We look at other aspects here. Widespread distribution of contraceptives is a way to see population, crude birth rates lowered. Family planning is obviously the big one. And public service announcements that offer education about reducing population rates is something that we see in other parts of the world. It's being done currently in sub-Saharan Africa too. Then we also have government policies that are put in place to do the opposite, and that is to increase the crude birth rate. So governments might encourage larger families. And so this is an expansive population policy. We've seen it historically done in different parts of the world. Maoist China, so it was when they were the communist China, or to begin with, when Mao first took over, they encouraged families to be very large. The former Soviet Union was encouraging families to have very large families and continue to have more babies. We see Russia actually recently, in the last couple of years, Vladimir Putin put in an offer for $10,000 in subsidies to women who had a second and a third child. In 2005 in Russia, they had what they called National Day of Conception, which if you conceived on a certain day and then you had a baby exactly 9 months later, you would win a prize. And prizes varied from cars to washing machines to whatever it may be. But yes, they put in that National Day of Conception. And there's some other countries there. Denmark is one that has had a number of pro-natalist advertisements, and they call their advertisement campaign is "Do It for Denmark." And so there's all kinds of different ideas of how to raise crude birth rates here for countries. And so the ultimate question overall, though, especially when we look at like sub-Saharan Africa, is how do we slow population growth? We've got a lot of people in the world, and we need to worry about slowing that population growth. And we kind of can talk more about what Hans Rosling had said in his videos that we watched. The idea of decreasing crude birth rate is necessary. This isn't something that we should try to do. It's something that needs to be done. The world crude birth rate has declined over the last 20 years, and it can be influenced in 2 ways. The number one is economic and social development. Educate women in those underdeveloped nations around the globe. If women have education, they tend to wait to have children, and they will have less children because they will wait until they're older when they have their first child. Also, making sure that those women have access to contraception is a huge aspect. These are the 2 factors that can most influence crude birth rate, especially in those countries where we see high total fertility rates and high crude birth rates. So there is a connection between the growth rates and the status of women, as we've talked a little bit about. The idea here is cultural traditions that tend to favor men and restrict educational and professional opportunities to women. We tend to see higher natural increase rates in those countries. And so you'll take a look at anything that's in that kind of orangish band on the far left there. Those are all African nations, and you can see that the women there tend to have higher the countries tend to have higher natural increase rates. And we saw earlier that women there tend to have higher total fertility rates. Those are also countries that tend to restrict professional opportunities and education for women. Here's the idea of family planning, and we can see in those different countries, Germany being our more developed country, China being kind of our newly industrializing country, and Nigeria being our lesser developed country or developing country. You can see the different methods of family planning done in those places. And largely in Nigeria, in our lesser developed country, there isn't any method being used. And so that's where we get to the idea of educating women socially and economically, and making sure that people have access to contraception, being very important in sub-Saharan Africa. And so here's your family planning use over the world here. You can see the areas that are using it more than others. And again, sub-Saharan Africa pops up as being on the lower end of family planning use. This one's not in your book, taking a look at other factors that lead to declining birth rates. Russia has showed a lot of the issues of this. We've seen declining birth rates in Russia. And we look at after the Soviet Union collapse, poor health, alcoholism on the rise, specifically amongst males in the Soviet Union, and poor economies led to a lot of drug use, led to a lot of male life expectancy being lowered, and that then led to lower crude birth rates. We also look at urbanization as being a big one. More urbanized places tend to have lower total fertility rates. If you're in an urban place, one, it's expensive to have kids, and two, you don't need a large family to help you farm and get your food, right? Because if you're living in a large urban area, you're probably not farming for your food. You're probably not subsistence farming, and you don't need those children to help you farm to survive. There's also cultural traditions and religion that plays a major role in some of these declining birth rates too around the globe. So back to our epidemiological transition. We've kind of talked about this stage 5, and we've looked at some of these issues with it. When we look at stage 5 and the epidemiological transition, stage 5 of this transmission, we look at we look at infections and parasitic diseases starting to reemerge. And so evolution is one of the big aspects. We look at new diseases that might be resistant to antibiotics that we've created. So things like malaria and some mutated diseases are starting to pop up today. We look at poverty being a major issue in some parts of the world, where we start to see reemergence of old diseases. Things like tuberculosis tends to be high in poor countries. We also see those poor areas where we tend to see high HIV rates as well. And a lot of times in those areas, they're lesser developed countries. They lack the access to medicine and the technology they need to prevent those diseases. We also look at connections globally. Global transmission through travel is a big aspect. And we look at literally these epidemiological reemergences happening because of relocation and then contagious diffusion, where you have someone literally moving to a new place, coming, and they have the disease or the virus, and they bring it with them. And so we have to look at our picture there on the right. How does COVID-19 fit into this stage of the model? It fits in perfectly, actually, when we look at the idea of epidemiological transition. We look at this idea of these reemerging diseases, or these new kind of evolutionary diseases like this that has become a global pandemic very quickly. Okay. So we look at the term consumption, which is tied to the disease of tuberculosis. And you can see it is definitely tied to poverty. Places that people are dying of TB are places that we see tend to be lesser developed countries or developing countries for sure. Okay, throughout sub-Saharan Africa, throughout South and Southeast Asia. So switching gears, ladies and gentlemen, we need to look at this man right here. His name is Thomas Malthus. So 1766 to 1834 is when Thomas Malthus was alive. And this man has an interesting theory that he creates here and comes up with. And he is an English economist. In the year 1798, he wrote a thesis that talked about the idea that population will outgrow food supplies one day. And so he proposed that in order for us to stop having so many babies and hopefully stop our population from outgrowing the food that we have, we should all practice moral restraint. In other words, he's saying, keep your pants on. All right. Now, that obviously we've talked about other methods as we've talked through today. But when we look at Malthus and his study, why did he feel this way? Why did he see this as a major problem? He was an English economist in 1798 when he created this thesis. And he was seeing England and London going through stage 2 of the demographic transition model. And what happens in stage 2? Population boom, right? We see a population growth, and that's exactly what was going on there, right? He didn't realize that, hey, maybe one day the population will continue and we'll see the the birth rates start to lower as well. All right, but Thomas Malthus and his theory have kind of set the stage for other people too. And so we look at Malthus, this was what his theory said, is that our resources are not going to be able to keep up with the number of people we have. And so we look at up to about the year 2020, as where we're at right now, our population and resources have stayed pretty even. But the argument that people today use for Malthus's theory is that it's very possible that we won't be able to continue to increase our number of resources, and our population will continue to increase as we look at from 2050 all the way to 2100. And so that huge gap leads a major problem. If we don't have food, if we don't have resources for all those people, then we have an issue. And so people do believe that Malthus was correct, just that he was maybe ahead of his time. Those people are called neo-Malthusians or new Malthusians. And they believe that there are kind of two current trends working here to prove his theory. And number one is the highest growth that we see today is in poor countries. Those poor countries are seeing demographic transition model stage 2, right? And so as they grow, they are going to outpace the amount of food that they have for themselves. And we also see then that there's a high dependency on other resources for other places, not just food, but water and energy could be actually what it comes down to, right? We obviously need energy to create the food and the water, and we look at the water as being an issue because we need that to survive as well. And so as a result, what people who are neo-Malthusians would say is that we're seeing more war, we're seeing more civil violence, and we're seeing conflict from one group to the next over competition for those resources that we all need. And so if we look at other resource issues that we might see that could lead to global conflict. I mean, we've seen water, we've seen oil, we've seen any of those fossil fuels. Those all could lead us to war because we are losing some of those resources that we have. Okay. So we look at people who believe that Malthus is actually wrong, would argue that these anti-Malthusians say that our supply of resources isn't fixed. We've continued over history to increase our amount of resources that we have. And so there are more resources available today than we have had in the past. Our population growth could actually stimulate economic progress. And maybe we start to do even better than we had been doing. And we learn new methods of farming, and we learn new methods of resource collection. Human welfare issues are also caused then by socioeconomics, as they argue. And so they talk about this idea of distribution versus supply, right? We have enough food today for everyone in the world. The issue is trying to get it to the people that actually need it. And that's what some of those organizations like Feed My Starving Children try to do, is make sure that they're getting the supply of food that we have enough of for everyone, is actually making it to those people that need it the most. So there's one from a green slide, not from your book here. We can see Thomas Malthus's idea of food production actually being confined spatially. And so when we talk about that, what people ate in his time was confined to the country that it was grown in, right? Today, our global food chain is much larger than that, right? We can get things from all over the world, basically any time of the year, right? We can get here in Minnesota in the dead of winter, we can get strawberries and avocados, right? Where if we look at Malthus's time, that was not accurate. He could not get those things. He could only get whatever was being grown in his country at that point, or even locally at that point. So our economy, our global interconnectedness has allowed us to have these other products throughout the world and throughout the entire year. Another one that's not in your book is Esther Bosserup and the theory that she came up with, and that's looking at anti-Malthusian, the anti-Malthusian side of things. She was a Danish economist, and she argued that an increase in population could actually stimulate scientists and farmers to come up with new production techniques. And so she said that necessity is the mother of invention. And so her idea is that if we have a larger population, in that larger population could be the next Albert Einstein, and he might invent a new process of food gathering or resource collection, and that could change everything, right? And so that's kind of the argument behind Bosserup's theory. And so as we look at it, the example here is that productivity has increased. When we look at reclaiming land from the sea and selective breeding and crossbreeding of specific crops, creating genetically modified organisms for food, developing new high-yielding plants. All of this we'll get into when we get to agriculture. Terracing for farming, hydroponics, so that you don't need to use the soil even to farm, the use of greenhouses and irrigation and artificial fertilizer, and all these things kind of go along with the fact that we have increased our food supply by all these new methods of farming that we've come up with. And you can see and we'll get to this more when we look at agriculture, but India has been able to increase their production of food during this time as their population continued to increase by these new methods, the genetically modified organisms, the high yield seeds, and what we call the green revolution. And we'll get to that when we get to agriculture later on. One thing that is becoming more and more common around the world, and even in the United States, is this idea of entomorphology, and that is the consumption of insects. So when we look at this, you may go to stores and you might see sometimes like the gimmicky little package of like crickets or something or chocolate covered crickets. That is becoming more and more common in the U.S., but this is pretty common worldwide. I mean, this is a food insect stall in Bangkok, and you can see that all the different types of insects that are eaten, and this is, again, common in other parts of the world. We look at it as kind of a taboo thing, like it makes us squeamish to think about eating bugs, but it's pretty common in other places. Although we are starting to see that they are, in the United States, grinding the bugs up so they create kind of a protein powder. And it's actually pound for pound very high in protein to eat bug protein, basically. All right, so this could be a way that we change that issue that we have with resources. That's it, ladies and gentlemen. So good luck, and we'll see you again soon.